Muy bien. Pues
Wonderful.
bienvenidos a todos
Welcome
nuevamente
everyone
a esta
once
nuestra
more
serie ECO,
to our
Intervención
ECHO
Nutricional.
series, Nutritional Integrated Intervention for the Management of Chronic Conditions in Primary Care. My name is Noquel Marrero, and I'm going to be your moderator today. I want to remind you, to all of you that are connected, that we have interpretation services, and you can access it through the interpretation button, and you can select there what room you want to listen in. We have a Spanish room, but we also have an English room, and you can choose that if you so desire. And before discussing the agenda, I want to remind everyone that is connected today with a mobile device or a smartphone or a tablet, remember to use the three buttons and rename so that when we create your certificate, it has the correct name in your certificate. The agenda that we have programmed for this afternoon includes the general guides, the description of the telementoring project, interactive telementoring for professionals, the ECHO methodology, clinical cases, information on continuous education credits, evaluation, uh, metrics, pre-test, didactic, post-test, presentation and discussion of the case, and we will close. And the series also provides you the opportunity of getting continuous education credits for doctors, nurses, and registered nutritionists and dietitians. You will see in the chat that there is a registration form. If you haven't done so, please do so now. Register there. When with these credentials and your participation, you will be able to receive those continuous education credits that are 1.5 credit per session. So remember to fill out your registration form. And if you have done it already, you don't have to do it again. And remember to participate. You can comment in the chat. You can raise your hand. The team here from the Institute of Public Health is going to be supporting us so that we can call on anyone that might have a question, comment, even if you're in the chat. And as always, please turn on your camera if you can. We want to know you. We know that a lot of you are in clinics. So thank you for being here with us this afternoon. If you can, actively participate, share your experiences. And this is a space where all of you are welcome to learn and to teach. Also, I want to mention that we use the ECHO methodology, and that has 4 principles of the methodology. That is to apply technology to make the most of the resources that everybody learns, everybody teaches, because all of you, experts and participants, can share best practices, and these practices have to be evidence-based so that we have a better quality of attention to the patients. This is learning based on real cases that come from participants and, of course, an expert in the topic. And we're going to evaluate satisfaction using metrics so that we can create feedback, a cycle that is good. So if you're registered, you can see all of the topics that we're going to be discussing. If you want to bring a case forth, you can send it to our emails, and we are going to use it in and as part of the session. So to make the most of your attention with me, let's go into the pre-test. You're going to see it right on your screen. It is already activated, and you are going to see several questions. So I'm going to give you a few minutes so that you can access the questions, and you can also use the link in the chat or the post area or the QR code, scanning it with your phone camera. Very well. In the meantime, the pretest is going to be available so that you can fill it out during the session. And I want to now talk to you about today's topic, which is session 3 of this series. It's nutrition in cardiovascular and hypertension risk. And I want to invite our resource, Keyla Ortiz, licensed nutritionist and dietitian. Let's go, Keyla. Thank you and welcome. Hi, everyone. Thank you all for being here with us, and thank you for the invitation to the Institute of Public Health. And I want to introduce myself. Nicole Marrero already mentioned my name, but this is my second intervention here in the ECHO program. I am very happy to be participating in this program, and also it allows us to integrate as a community in anything that has to do with health professionals, and I'm so happy to be here. I am located so that you can have a little bit of information about me. I have a private practice in the medical tower in San Fernando, Carolina, and my practice has to do with nutrition for chronic conditions. So I'm very happy to be here. Very well. So we are going to be speaking today about the nutritional intervention when there's a risk of cardiovascular and hypertension conditions. And I'm going to try to be brief with the information because it's a lot of it. There's a lot of information. We could be here maybe with a workshop, but I want to give you the most important information and that we can use in our respective clinics. Among the objectives is that we're going to be evaluating cardiovascular risk using practical tools, complementaries to the clinical history. We're going to identify opportunities for what we see as the early referral to a nutritionist dietitian. We want to promote sustainable changes in lifestyle as a part of integral treatment for patients with hypertension and cardiovascular disease. And we want to incorporate messages that are brief in terms of nutrition. They're messages that are brief and easy to apply and that are effective while we're in the medical consultation. Cardiovascular disease, as we know, are the #1 cause of death worldwide, and hypertension, even though it's not known as a cardiovascular disease aspect, it is one of the risks for this disease. So the evidence today recognizes that nutrition is key to the management of this type of diseases, hypertension and cardiovascular diseases, with pharmacological therapy for prevention and management of these diseases. When we talk about cardiovascular disease, this is maybe an introduction to this. We are talking about coronary disease, cerebrovascular disease, cardiac insufficiency, arrhythmia, uh, and other diseases as we see in the screen. And we're talking about hypertension, even though it's not classified as a cardiovascular disease, it is the main risk factor of this disease, where it's a acute uh, infraction of the myocardium and all of these conditions that we see here on the screen. So what are we going to be considering? We receive the patient and we should take a look at what we want to see what the risk is, what is their BMI, what is their clinical history, their nutritional situation. If we are in a nutritional consultation, of course, this is going to be the most important thing. But if we are in a medical practice, we want to know at least their weight, the BMI, circumference of their waist, height, and all of the recent changes in weight. We want to see how they eat. And based on what the patient is telling us in the consultation, we are going to be able to emphasize on the initial recommendations and see how we're going to work the interventions. So the quality of what they eat, how they consume sodium, fruits and vegetables, ultra processed foods, and saturated fat. Of course, lifestyle. In a consultation for nutrition, definitely we are talking with the patient throughout an hour, maybe 30 minutes, and we can go in depth about their lifestyle. But that is something that we have to touch on in consultation. We want to know if they smoke, if they use alcohol, if they're sleeping well or not. And the medical treatment, if they're using medication the way they're supposed to, sometimes patients have high cholesterol because they're not using their medication, or maybe they take it one day and let go the next day. So everything about how they use medication is something that we should talk about in the evaluation. The interaction between foods and medication, whatever supplements they're using, because there's a lot of people coming in with several supplements, and sometimes they're using too much of the supplement. And sometimes one thing interacts with the other, and it's not as efficient as it should be. And of course, whatever we get from the labs, we want to see how their liver is doing, their A1C, their renal function, and their pressure. Many times we get a patient in our office that has objectives more than their blood pressure or the cholesterol. They might be controlled in many areas, but we still have to look further because there are other indicators that allows us to know that the patient is still in a high risk to have a cardiovascular accident. And what is it that we need to look at? We need to see visceral obesity. We need to check that circumference and the weight and the waist, weight, and height. We want to know if they have problems of chronic inflammation, if they don't exercise, if they're not sleeping well, if they are smoking. So even if they have the first part of this table controlled, we need to look to the bottom part of the table and take all of that into considerations. And what are the benefits of nutrition in this type of scenario? It allows us to bring down the systemic inflammation, visceral adiposity, endothelial function, uh, get the arterial pressure down. It can improve the lipid profile and it decrease the risks for cardiovascular accidents. And before going into nutrition, the food, the patterns, I want to mention certain nutrients and foods behavior before I go into the patterns themselves that are every day more evident that allow us to help and diminish cardiovascular disease. In terms of sodium and hypertension, we have seen, and I'm going to show you some studies. We see if people use less sodium, the pressure will go down, the cerebral vascular accidents diminish the risk, the hypertension, and the progression of hypertension. So one of the things that we can recommend as an ideal objective from the HAA is to have less than 1,500 milligrams a day. But for a clinical benefit that is significant and that is considered, if we have less than 2,300 milligrams, we've seen a lot of benefits from that. And some of the practical strategies that we can start using in the consultation in a general manner, because of course, when we go deeper into the nutritional, we can talk about products, what are the products that people are using and what are they ingesting most often to be able to have a more precise scenario of the sodium ingestion. But 5% or less of sodium, that's good. It would be 140 milligrams in the label. That will allow us to choose the right products. And something happened to a patient that I had in consultation. They had really high blood pressure, and he was drinking whole milk, half a gallon. So sodium was too high just because of the milk they were drinking without taking into account other foods. So when we went into adjusting the milk, they had a better scenario in terms of their arterial pressure and hypertension. So knowing about this and if they're eating spam, if we teach them to read the labels, to look at that 5% or less, you're not going to find spam of 5% or less. It has like 36% of sodium. That visually impacts and allows them to be aware of what they're selecting to eat. So labels are very important in these practical strategies to use other things other than salt. When you're cooking, you can use garlic, you can use lemon, you can use all of these things instead of uh, commercial condiments so that they can control the use of salt and other things that are so high in sodium. In terms of ultra processed foods and the association with cardiovascular, uh, of course, it is associated. It increases blood pressure because a lot of ultra processed foods are, of course, very high in sodium and saturated fat. Uh, among other added ingredients such as sugar, and that will contribute that visceral adiposity. It heightens our propensity for diabetes 2, metabolic syndrome, etc. And in order to know if the food is ultra processed and what is considered ultra processed, they have multiple ingredients. They have additives such as color, emulsifiers, etc. And it has high content of sodium, added sugar, saturated fats, trans fat, and it doesn't have much in fiber and whole foods. In terms of saturated fats, and we've had evidence throughout the years that that makes LDL cholesterol go up, and that is one of the main risk factors for cardiovascular disease. And I'm going to be showing you what the studies say when we substitute the bad fats with good fats, we can see a significant improvement in the cholesterol panels. But also, studies have been searching for and finding if the changes in carbohydrate, refined carbohydrate, there was an impact. We didn't see as much as an impact when we use the good uh, fats for the bad fat. So we can see on the screen the different examples, but of course, in a particular consultation, we can really talk about what each patient is using. And it's not only fast foods and excessive eating, or maybe a restaurant where there is no control. When you go to a restaurant, you have no control in terms of the process in which they prepare the food, what they add, so that it's the fat that they add so that the food looks better, better presentation, tastes better. So between the fat and the sodium that is added in fast foods and restaurants, it's difficult to control what each person is ingesting. So in some of the products that they're using, you can identify and create substitutions that are aware, conscious, and we want to limit the use of bacon, butter, processed meats, um, coconut, or palm oil, which are very high in fat. And of course, the cheeses that are usually high in fat. So we want them to give them that other product that they can use, as you can see to the right of the table, that you can find substitutions. And of course, uh, better meats, ultra virgin olive oil, uh, avocado oil, canola oil, sardines, eggs. You can do this gradually, and you can teach your patients to do it gradually so that they can find substitutions in their and what they like and what they prefer. There's a lot of vegan products that have a lot of saturated fat and a lot of sodium. So that is something that we have to discuss with patients, because sometimes they think that because it's vegan, it's going to be healthier. But many times this type of product, or to eliminate uh, animal-based food and buying all of these protein imitation vegan products, maybe it's not as good as you might think, because they have other ingredients that will increase sodium and fat. And we should, in our consultation, talk about what product they buy, the quantity of the products they buy that might be, well, I put them in the microwave, or it's, the products that are very easy to prepare and very fast to prepare. And there you can realize if there's a lot of sodium and fat consumption, because usually these products that are easy to prepare are high in both. So, briefly, from the vegan side of products, we need to check on that. Trans fat, for many years, we've been talking about this. We have evidence about this. And the Association of Heart Health, American Association of Heart Health, we need to take this into consideration. We know about trans fat, and we know that it's in products that you buy in fast food. There's going to be high in uh, the chips that you buy in bags, all of these are high in trans fat. So it's easy to check this in the label. But aside from that, we need to tell them about other places where this is going to be found when the vegetable oils are uh, emulsified, hydrogenized oil. We have somebody with their microphone open, and we need them to close, please. So we want to know what the impact is, because they get the LDL to go up and they decrease the HDL, which is the opposite of what we want. And it heightens the risk of coronary disease, cardiovascular infractions, and death. Bread, and all of those delicious foods that we like to eat, and sweets, solid margarines, creams, among many other products. And they need to know that. And we have the patterns that is based on evidence, which is a DASH diet for the prevention and management of hypertension. It has a lot of evidence, and what they do is to focus on those nutrients that will protect your cardiovascular system. You can see in this plate what we are looking for them to follow. And what are the main issues of this? Well, a lot of fruit, vegetables, whole grains, legumes, nuts, seeds, uh, good fish, fowl, meat, and the use of olive oil and unsaturated fats. You can see here. And what is limited? We don't want the sodium. We want it less than 2,300 milligrams. We want less saturated fats and trans fats. We want less processed meats. We want less soda and sugared drinks. We want less ultra processed foods. We want to reduce the risk of cardiovascular disease. And if we combine this with a Mediterranean diet, that is what we recommend, we know that this works on hypertension and cardiovascular health. This study is for the DASH diet. It's a systemic revision where we had 15 studies of prospective cohorts. We had some 942,140 participants. We evaluated 31 clinical tests, and we observed that if you use DASH diet, you have 20% less risk of cardiovascular disease, 21% less risk of coronary disease, 19% less risk of cerebrovascular accident, 18% less risk for diabetes type 2. It allowed systolic arterial pressure to go down, diastolic arterial pressure to go down, LDL cholesterol went down, weight went down, and A1C went down. And that is for the DASH diet, that although there's a lot of evidence for both things, hypertension and cardiovascular disease, the main focus is for hypertension. That has an impact for cardiovascular disease. In terms of the Mediterranean diet, which is one of the patterns that has the most evidence for cardiovascular health, it is very similar with the DASH diet, but the priority here is have minimally processed foods, healthy fat, extra virgin olive oil, fruits and vegetables, whole grains, legumes, nuts and seeds, fish 2 or 3 times a week. That is a lot of what is the priority. And of course, we have dairy low in fat. But for example, sardines, salmon, that has a lot of omega-3, that's what we're looking for. And fowl and meat that is healthy is promoted in this diet. But we want more of whole foods and minimally processed foods. The benefits is less um, risk in cardiovascular events, LDL going down, arterial pressure going down, inflammation going down. So you're going to have a better metabolic health. So it's very similar to the DASH diet. And what is the American Heart Association telling us? What is their posture in this? Is it that they want? We need to do away with saturated fat. We want more vegetable uh, oil. We don't want that much processed meat, tropical fat. We don't want that much of the fat that we find in butter. We want more fruit and vegetables, whole grains, legumes, nuts. Uh, you can see here to reduce sodium is very important. In terms of the Mediterranean uh, diet and the study, the one that we spoke about was the DASH diet. but we had 7,447 adults with cardiovascular risk in the high area. Uh, we had a clinical test. The control group had a low-fat diet. The other group had the Mediterranean diet plus extra virgin olive oil and the Mediterranean diet with nuts. So the first one had 30% less major cardiovascular events, such as uh, myocardiac accidents, cerebrovascular cardiac accidents, etc. And here we already spoke about the patterns where the evidence is the Mediterranean diet, the other diets. We need to be able to check on these, which are the ones that affect uh, cardiovascular health and hypertension.
Now we are going to talk about 3 practical tools that I want to mention that you could use in your consult. It doesn't take a lot of time, and they help us to be more aligned to what the patient actually needs in a holistic way. Number one is the ways to hide ratio. We discussed this previously in another session, and this is a tool to identify cardiometabolic risk. In this example that we can see here, we are taking the measurements with a male patient. He has a height of 68 inches and a waist circumference of 36 inches. When we divide it, the ratio is 0.53, larger than 0.5, it is an elevated risk. So in this case, with 0.53, we need to see this patient with an increased risk. And the other tool is a calculator that it comes from the American Heart Association on their website online, and it is very quick. And it is free, and they evaluate cardiovascular risk at 10 years, 30 years, infarct, cardiovascular accidents or strokes, kidney disease risk, and metabolic. And it was evaluated, this data, with more than 6.5 million adults, with a very large sample, and it helps to evaluate that risk. This takes into consideration if it is male, female, cholesterol level, blood pressure, age, glomerular filtration. They take into consideration if the patient smokes, if they have diabetes, if they are taking medications for blood for high blood pressure and for cholesterol. And according to all the data, or they also ask about the A1C, but according to this main data, they do a calculation and they learn about the risk. And the other one, practically, it takes a little bit more time, from 16 to 20 questions, but it is very useful. It is known as RIB, your rapid eating assessments for participants. It takes from 5 to 10 minutes. It is completely validated, and you can see here an example of the questions, but it is a format that it could be modified with those same questions. And maybe we can do it digitally, so we self-calculate. We can make it more accurate, but we shouldn't avoid any of the questions because it is a calculation that determines if the patient needs any nutritional consult with more urgency. So it is supported by the American Heart Association. It evaluates the quality of the nutrition and it facilitates nutritional consultation or counseling because based on these results, the physician or the healthcare professional could provide preliminary recommendations while the patient goes to see the nutritionist and they could go more into details. So now we're going to see the clinical case. Here we have the references and the clinical case. When Nicole is going to discuss it, it is a patient, a current patient on my clinic. So we're going to be able to discuss it and to see what are your recommendations. Thank you, Kayla, for this excellent presentation. And before we continue with the clinical case, I am going to share the link for the post test. Here we can see it. And also you may be able to see it on the screen. You can scan the QR code or you can click the link that you may find on the chat. So I am going to give you a few minutes so you can do the post test. And after that, we're going to continue with Francelis. She will be introducing, together with Kayla, they will be discussing the case. So let's continue with my colleague, Francelis. So we may start with the clinical case or the case study. Good afternoon. Today we have a patient, a male patient. He's 60 years old. He was hospitalized because of a ischemic. Uh, he has type 2 diabetes, dyslipidemia, uh, class 3 obesity, and asthma and high blood pressure. And they want to reduce the cardiometabolic risk and reduce the risk of a second stroke. And he doesn't know how to cook. He rarely cooks at home. Practically every day he goes out to eat. He goes to restaurants and fast food restaurants, and he also buys pre-cooked foods, canned products, pre-seasoned food, and ready-to-eat foods. Also, he didn't monitor his blood pressure at home, and he is mostly sedentary. In the next slide, we have that after the stroke, he made some changes by his own initiative. He decreased the intake of sodas and candies and pastries, desserts. However, he's taking aspirin, 81 milligrams, clopidogrel, atorvastatin, losartan, metoprolol, hydralazine, spironolactone, Sejardi, and Jardians. In terms of proprietary, he has a weight of 267 pounds, 5'6", high, BMI of 43.2, waist circumference of 49.5 inches, body fat percent of 49.7%, and a muscle mass of 75.6 pounds. And here we have some discussion questions, some prompts. So I invite all of you to participate in this discussion. We have nurses, physicians that are joining us today. So you can provide your recommendations using the microphone. You can raise your hand or just open the microphone, introduce yourself, and provide your recommendations. And the questions are what factors for this cardiovascular risk can you identify in these patients? We can go to the next slide. Here we have the information regarding this case. This is certainly a patient that you may see frequently in your work. Any recommendation is welcome. Mara Perez, please go ahead. Hello, good afternoon. It's Mara. Well, I have not been able to rename myself, but yes, within the risk factors of this patient, we can see that obviously they have hypertension, diabetes, and dyslipidemia, and he has an obesity. In this case, I think it is morbid. Uh, and if the patient continues eating fast food, as it was mentioned, and even though they have decreased the up to 67, I think it is, if I am not mistaken, at least in diabetic patients, they should have an LDL lower than 74. And that's one of the recommendations. Also, they could use a DASH diet. That's another recommendation from the American Heart Association guidelines. And within the medications, he is in high intensity statin like atorvastatin, and he should continue taking it because he's diabetic and the patient already has apparently he already has heart failure. I understand that they have the 5 pillars right now, so on that end he's covered. Also, we should include, since the DASH diet, and it is important also exercise at least have an hour to 45 minutes, 3 to 4 times a week at least, so they can keep that condition on a stable situation. I understand that that should be all. I don't know if I am missing anything according to the questions. Let's see. And also in terms of the calculation, I would need to use a present. At least in our clinic, we use the new calculator prevent. We started using it since it was updated. So on that end, I would need to sit down and do that calculation. And then in terms of the goals for the next 6 months, obviously, even though we need to see the economical factor for all the patients, not all patients have the same availability and resources to be able to follow the suggested diet, but at least to re-educate the patients in cooking more at home and to avoid fast food, canned products with a lot of preservatives. We need to increase also proteins, soft white proteins to reduce red meat proteins. We also need to increase the intake of grains, and in this case, everything that has to do with the Mediterranean diet, and also to increase exercise altogether with the prescriptions that he is taking, and they need to be in compliance with those. Thank you. Thank you for your recommendations. Any other recommendations from another participant? Yes, at the end, the nutritionist is going to give us some closure. In terms of the laboratories, I don't know why I am not able to include them in the presentation. Let me see if I can include them. Nicole, can you confirm if you can see them now? The lab results? Yes, allow me just a moment, please. While Nicole is able to show us the lab work, we have an A1C, a fasting glucose of 122, 7.6%. In terms of lipids, the total cholesterol 146, LDL 67.8, HDL 63, triglycerides 76, kidney function, creatinine 0.82, EGFR over 90 milliliters per minute, VUN 19 milligrams per deciliter, microalbumina 127.8, albumin to creatinine ratios 50.63, vitamin D 20.7, neutrophils 74.6, and leukocytes 13.5. So this, take it into consideration the blood work. Do you have any other recommendation? Okay, no, is saying that they should have a follow-up appointment every 3 months to confirm adherence to the treatment. Okay. Juan, please go ahead, and then Martha Garcia. Yes, good afternoon. Hello. In addition to what our colleague mentioned previously, which was excellent, this is a patient that I think that we could also visit them at home to see how they live, to see also how is a psychological condition, and we could review their history with pH Q9 to rule out if the patient is showing any changes in their mood, if they are depressed, and maybe that's why they are more careless in their nutrition, because definitely this is a nutritional emergency. The patient needs recommendations immediately in terms of their lifestyle, changes in their lifestyle and in their nutrition, definitely. But we need to evaluate that psychological aspect. I don't know if he's in hypocycloxin because of hyperthyroidism. So we should also evaluate TSH to rule out the levels of thyroid. Let's see, we have a patient with hypothyroidism and obesity. It changes in the mood. If they're a little bit depressed, we need to work on that as well. And also, he has an A1C of 7.6. It is a little bit high in morbid obesity in 43.2, definitely. So this is a patient that could benefit from weight management, but definitely they need to do nutritional changes. They need to prevent going to the fast foods if they are not able to cook. That's why I say, and I mentioned that we need to visit them at home. If they cannot cook their own medications, we need to find a way. Now we have the free meals if they can afford it through these free meals, those portions. So every week, they could help him to control better his weight. There is a new concept that it's been discussed about the ApoE proteins, Apple V and Apple 1. It would be interesting to order this test to verify if the patient is at high risk, because he already had STEMI, a myocardial infarct with an elevation of ST. So possibly not a STEMI, but already the patient, if they already have this risk factor for the myocardial infarct. So these are the new concepts that I am listening, the Apple 1 and Apple B, that let us understand the risk factors regardless of the bad eating habits. regarding processed foods or alcohol, tobacco use, and people who are not physically active. So these are independent factors that are going to help us to evaluate this kind of patients. So this patient requires a multisystemic assistance. We need to evaluate their psychological condition. Seeing the nutritionist is so important, and the medical management with the primary care physician, the cardiologist, endocrinologist. Well, a full power evaluation. So that would be all on my end. Thank you for the opportunity. Thank you so much, Dr. Roman. And we can go to Marta Garcia. Good afternoon. I think it's an interesting case. It illustrates many things, but also it is a case that we see very frequently. It is a reality. We see it day to day, every day. So I think that the two colleagues have made a very comprehensive analysis, because this is a case with advanced cardiometabolic disease, with risk factors of obesity, diabetes, hypertension, and early diabetic nephropathy. And they already have evidence of damage to the organs. And now the emphasis, maybe it is aggravated by important social barriers to a good nutrition and also to modifications in lifestyle. Because with this, which is included in the case, exactly how it is the process for their nutrition, I think that is the most significant aspect of this case. He has metabolic polypharmacy, which is expected in this case. So how to manage it, that's what we have. But it's not only a patient that is not eating well, but they are living by themselves. They don't know how to cook. They are eating out at restaurants almost every day. Sedentarism. They don't have maybe monitorization. They don't have a good education in terms of nutrition. So I think it's really important what the doctor mentioned about exploring the emotional aspects. So we could tell the patient they could try the Mediterranean diet with fish 3 times a week, with quinoa and vegetables. That is not implementable. That is not real for these patients. So the nutritionist is smiling because she knows how this works. So I would say that in this situation, more than obesity and diabetes, the therapeutic objective is also to teach them, to educate them how to eat. And the other aspect is that they have a history of asthma, and that indicates that they live in a condition with inflammation, with that phenotype that we call inflammation. But if we help him to reduce the inflammation with fiber, vegetables, omega-3, and less ultra processed food, and if they have a sustainable weight loss, we could help them with everything, because these risks are shared, the mechanisms are shared. So we need to educate him how to purchase food, the prepare meals, it's a good option. Frozen food could be useful, but we need to monitor them uh, very carefully. So we really need to educate them in terms of nutrition. And I am very concerned about people who live by themselves, because they have a heavy burden. So this is a super case. It really translates the day-to-day reality. And these are things that we are not used to explore it only in terms of pharmacology. We also need to pay careful attention to the kidneys, because they already have evidence that the kidneys uh, are already suffering. So I think it's important, as a summary, to address the social barriers individually for these patients more than biological barriers, because we are already seeing them. The person who prepared this evaluation did it very well, because they asked about everything. So thank you so much for sharing this clinical case study, and we can share it with our students. Thank you so much. Thank you so much. Thank you for your comments and your recommendations. Very well. So thank you so much to all of you for your contributions and for all those recommendations that you provided. It is a very interesting case. It is one of my cases. He started with me in March. So the lab work that I shared with you are from February. I didn't share with you the ones from June. I am going to mention them now. But this is a case that it was perfect for this discussion today because it has all this in terms of cardiometabolic. He is very compromised. So the patient, I think that Juan Roman mentioned, I don't know if he's a psychologist, Juan Roman, but from what he mentioned, I think that he may be. And I think that the patient, I apologize. I am a primary care physician. I have I got my license this year, so I am new this year. So you mentioned about mental health, so I thought that you were a psychologist, but this is really important. And the patient, he came to the clinic. He came out of the hospital. He very he came to visit us very close to his event, and he was very scared, sad, unmotivated. He had like a little bit of he still has some motivation because he was here at the clinic, so he made the decision to come to the clinic, but he felt very frustrated. So as he was talking to me, he told me a lot of information. It was a patient who took me more time than normal because to be able to gather all this information that I shared with you, we needed to find out a lot of information. So if I use the technology sometimes to take the information in advance. So he talked to me a lot, and that allowed me to gather all this information. But as you saw, he lives by himself. He has some family support. Sometimes they go to visit him and take him food, or he could prepare himself something quickly on his microwave oven, or maybe on the stove very quickly. He only warm up the food, or maybe he warm up a canned product, for example. So I needed to give him all the basic orientation, talking to him about reading the labels, because even though he doesn't go grocery shopping all the time, sometimes he does go grocery shopping, or when they bring him a grocery shopping, the grocery uh, with some family members, they bring him the groceries, so he tells them what to purchase. So I talked to him uh, so he could learn about this, and he could also share the information with his family members. I am seeing him every month. So we have seen many changes in him. It is very positive, and I am going to share them with you now. But uh, within the places that he goes most frequently, we were looking for healthy options among the places he goes to reduce the saturated fat intake. Also, his sodium intake was very high. So in terms of rinsing, the canned products, for example, the beans, the grains, also talking to him about the low sodium options. Also, I offer him some easy recipes. Uh, he was willing, he was listening to the recommendations, but I really needed to investigate if he was able to afford all these products. So he gave me a list of what he had available, and based on that list of what he had available, he only needed to purchase very few things, because with that, I explained to him about the portions. Some things I was not able to integrate them, but I educated him on why not. So I showed him the labels, And I explained to him why not. For example, corned beef, cold cuts, luncheon meat. When I showed him the label, he was very impacted. He had no knowledge about nutrition, not even a basic knowledge. So that was like uh, what we worked the most. So I uh, thought about a Mediterranean diet or dash, but no, on the contrary, that was one of the things that we worked later. But in all the recommendations that I gave him initially, we integrated principles from the dash diet and the Mediterranean diet. The only thing it was not a plan with portions. We work it differently. And the first things that he could take away was what to prepare at home. And the next visit, he brought me products of what he has available. We improve the grocery shopping and we improve his skills in the kitchen so he could prepare more things. And to give you a summary of a few things, we did the calculation, answering some of the questions that we saw on the chat in the waist to height ratio, he was 0.75. If you remember, more than 0.5 is at risk. So he has a very elevated risk in 0.75. Another thing that we did, I already mentioned about ultra processed foods that we discussed with him, and about the blood pressure. He already had the blood pressure meter. He's monitoring his blood pressure. He was not doing it before, and he's integrating more uh, food high in potassium and his kidney function. Before seeing the results, his kidney function, the results that we had were not what we have currently, so it really improved.
Possibly more related to what happened in February. Everything was out of control, and of course, what the behavior and consumption was. So we were talking also about getting up that consumption of fiber, eating more fiber, and how to interpret added sugars so that he would know more about that so that he could have a little bit more control of the glycemic index. My goal with him was 5 and 10% in 6 months. We've been working 3 months, and I'm going to tell you how we're doing. One of the other goals is that even though you're in a losing fat process, you would have muscle mass preserved. So in that, we also recommended exercise, physical activity, and we uh, print printed for them some sitting exercises and in bed exercises while he can improve his physical situation. After the consultations, he was very interested. He was never fail one of his appointments. We're seeing each other every month, and I want to discuss with you a little bit more of the results of what we've been doing. We started in March. We are in July already, and he went down from 267 in weight to 254.2, which are 13 pounds and some ounces less. So that moved us beyond the 5%. So that was very good. He feels different. He's another person. The person that is talking to me now is different from the person that I first met in March. The waist circumference was 39.5, 49.45. He went down to 47.5, so it's 2 inches less. The percentage of fat was 49.7. Now we have it in 46. So the impact for his weight loss has been mostly in fat, and we are preserving that muscle mass. There are some limitations, but that helps him see exactly where the impact is between fat and muscle. What he's lost in muscle mass has been 2 pounds. So it has been, progress has been evident, and the labs, because he was already a little bit controlled more or less controlled in the lipid panel. That was pretty controlled. But with all of these medications, the A1C that was in 7.6, it went down to 6. So that's a radical improvement. Microalbumins and everything is controlled. So this is just a summary that I've been doing of what I've been doing with the patient. Uh, I still need to see him every month. He's going to have an appointment in August. He is very happy, and I am very happy with the results we've gotten up to this point. So that would be all. Thank you so much for being here. I don't know if you have any doubts uh, on the presentation of this case, and I would leave it to the moderators now. Thank you so much, Kayla. We still have time for questions, so I invite any of you that might have a question, you can use the chat, you can raise your hand, you can open your microphones to make the most of the resource we have with us today. I think that there was a very interesting topic that was mentioned by uh, Mr. Ortiz. Yes, Keyla Ortiz, that it's not everything that's vegan is healthy. So we can't just believe that whatever name or label is given in the marketing of a product might help us. We need to still look at the nutritional label, at the nutritional table in the label. So, what strategy do you think we could use or would be better for a patient? Well, when the patient comes to me with the doubts, they're buying everything vegan, everything that's natural. According to what we're seeing as their behavior and consumption pattern, it's easier if we know the percentages. Of course, there's a limitation. The daily value in the labels is based in 2,000 calories, and not everyone is using 2000. Maybe it's 1800, 1600, but we know if you use a daily value, regardless to get to that 5% or 20% and up is too high, it helps patients to understand, wow, this is 16% saturated fat. I need to get rid of this product. This is 20% in added sugars, and this other product doesn't. What happened to me with the spam when the canned meat, when I showed him, well, it wasn't this patient, it was another one. But when I taught the patient and showed him about the milk that they were consuming, this person had hypertension. When he saw what he was consuming in terms of water, I'm sorry, not water, milk, and then the canned meats and everything. And I showed him what it showed and how it showed in the label. That motivated the person because I showed everything and he saw the percentage. For example, in the spam, it's maybe you eat the whole can instead of 2 ounces, and that's 36% of saturated fat. And they know now that that is too high, just too high. And so this type of concepts in terms of the nutritional labels are important so that you don't pay as much attention to the marketing terms, vegan, natural, organic. You need to look at that label. So the fibers, the good fats, uh, mono and poly, that is important to know when we're looking to the sodium, sugar added, saturated fat, we need to be in the 5% or less. That's very important. Thank you so much for the recommendation. That is good for everyone here to know. And of course, the recommendations to the patient. And I'm confirming that there are no other comments or doubts. I'm going to go. I believe everybody already filled out the post test. I'm going to show it once more so that you can help us in bringing resources and topics that are relevant to you and other ideas that you can provide for our echo sessions. I will let you know that this is part also The post test is also open still. And aside from that, I want to invite my colleague, Xiomara, who is also connected to talk about something that might be of interest to you. Go ahead, Xiomara. Hello. I'm here. I'm so sorry. It took a while. It's a pleasure to say hello to all of you once more. We want to share this announcement, this initiative that we are ready to begin. We are working on this, preparing for it. We need primary care doctors, gynecologists, pediatricians, uh, general practitioners, family doctors to participate in one of four listening sessions to share your experience in your clinical practice using digital tools. That's going to help us identify recommendations for patient care and support professionals in Puerto Rico. These sessions are going to be in person, and we're going to move to the different regions, north, south, east, and metro. We have already identified, according to what you see in the screen, August 13th, we're going to be in Mayagüez. August 18th, we're going to be in the metro area in San Juan. That is already sold out. We still have spaces for August 20th in Ponce and August 25th in Atillo. If any of these other locations is nearer to you or you enjoy them and it's not sold out, please use the QR code, scan it, and also, I'm going to offer in the chat the link for registration so that you can register and I can get in touch with you. If you already registered, you don't have to do it once more. I already have your information. This is more for the spaces that we still have open and available. We are going to have a limited number of participants in each one of the events, and this is uh, incentivized per participant, as you can see in the screen. As always, I want to say thank you for your attention. And of course, we are in communication. I'm going to be looking for whatever comment, question, or contact you offer. Thank you. Thank you, Xiomara. Well, we still have spaces in Mayagüez, Ponce, and Atillo. If any of these locations is near to you and you're interested in participating, you can register and be part of these discussions. And you can connect with other doctors, with other health professionals, and of course, from our colleagues from the Institute of Public Health. I also want to let you know that the presentation that is being recorded is going to be part of our digital library, and in recursos.prpht.org have 18 topics, 11 formats. We have more than 700 resources available. We have women's health, um, mental health, all sorts of topics. So we invite you to check the resources that we have available. If you want to go over any of the tools, you can use this library. And we're going to have our next bi-weekly session in these nutrition and cardiovascular and hypertension risk. We're going to have Maria Eugenia Rodriguez, licensed renal nutritionist, and we're going to have Dr. Edilberto Ocasio, nephrologist. This is going to be August 5th, 3 to 4:30. If you have any clinical case that has to do with a kidney patient and you want to let us know, we are here ready to talk to you and receive any information that you want to provide or any case. Aracelis is going to be part of the people that you can call. So I want to say thank you to our resource of today, and we'll see each other again. Thank you. Thank you all.
Good afternoon. Thank you so much.